Hello, everyone, and welcome to another awesome episode of Nurse Converse brought to you by Nurse.org. My name is Jeri Ford, and I am so excited and honored to be hosting yet another episode packed full of information that I think you guys are all going to find very relatable. This week's episode, we are diving into a very hot topic right now and something that I personally feel should be covered way more in nursing school because it's so prevalent and affects us every single day. And this is how to deal with toxic coworkers and nurse bullies. For those who don't remember, I have been a pediatric nurse for almost 13 years now, which I can't even believe saying that sometimes. 10 of those years, I was a travel nurse, which means I have worked with all types of personalities all over the country. I've worked within many specialties within pediatrics, like clinics, inpatient floor, step-down units. I'm now in the PICU, ICU. I've floated to countless other units like CT ICU for pediatrics, of course, ER. I've just worked in a plethora of units and I've experienced all types of personalities. And so I have many stories and I've seen firsthand many accounts as well. But even after these 13 years, I still feel like my ability to confront these types of personalities could definitely use some improvement. And that's why I'm super excited to welcome back my favorite nurse therapist, Danielle Palomares. Danielle, can you remind our listeners a little bit about you and your expertise?
Yes. Hi, Jeri. Thank you for having me back. I am Danielle Palomares. I am a trauma, attachment, and sex therapist that works with a lot of healthcare providers, and especially nurses and physicians. And I am just really excited to talk about this because this has been coming up over and over in sessions lately.
And I remember when we were talking about like what you have been seeing, you mentioned this and I'm like, oh my gosh, this is something that I feel like I said, I feel like nursing school should cover. That's how important it seems like to me because that's how prevalent it is, which as I was like researching for this article, I did find some notes. It says there is an article that I found on NIH, and I'm just going to read the quote really quick because I found it so interesting. It says, nurse bullying is a systemic, pervasive problem that begins well before nursing school and continues throughout a nurse's career. A significant percentage of nurses leave their first job due to the negative behaviors of their coworkers, and bullying is likely to exacerbate the growing nurse shortage. A bullying culture contributes to a poor nurse work environment, increased risk to patients, lower patient satisfaction scores, and a greater nurse turnover, which costs the average hospital $4 million to $7 million a year. Which was crazy. And you would think that nurse CEOs would be hearing this and be like, we got to do something about this. The other thing I saw too, the other stat that they said was within the first 6 months of post-graduation, 60% of nurses leave their first job due to the behavior of their coworkers. That shocked me. It didn't shock me that it happened. It shocked me that 60% will leave their first job. That's to me astronomical and not okay. So, and it sort of seems like the concept of nurse bullies seems foreign to those like in the outside community because they're like, nurses are amazing. How could they have bullies? How could this really actually be happening? It's probably not even that bad. But nurses are human, physicians are human, techs are human, and humans come in all forms, and all humans have good and bad moments. So because of that, it unfortunately is a very real thing in the industry, as I'm sure you've seen a million times yourself.
Yeah, it is unfortunately common. I think the hierarchical nature of so many hospital systems, unfortunately, like set the stage for this as well.
Right. So I guess to get started, because there's so much to talk about and so many stories, I feel like they're just like coming in my head even more than the ones I already wrote down in my notes. But do you see, so you already mentioned this a little bit, but do you see this often in the nurses that you work with?
Oh, yeah. And I think what I'm noticing lately is I'm seeing it more from nurses that are kind of freshly entering the field, like a huge shock of like, what is going on? I feel like I'm being hazed. Like that word keeps coming up and, over and over again. I feel like I'm experiencing hazing. Like this person's out to get me. And I'm not sure if it's in my mind, if I'm making it up, maybe I need to toughen up, but just a lot of self-doubt, a lot of almost like gaslighting of their experiences. But when we really look at it, like there are behaviors and there are things that nurses are telling me that are just really unfortunate and really toxic.
Yeah. And it's interesting that you said the new thing too, just because I am not new. However, I'm newly in the ICU role and, newish, like a year or so. And then I've of course floated before to different ICUs, but that's not quite the same as starting fresh. And I definitely feel that way now. I'm like, this is a whole nother world, which I can get that into a little bit, but it's interesting. When you're in that new role, I feel like you're more prone to
Yes.
having that.
Totally. And I'm seeing it a lot with transitions. So transitioning into new systems, into new departments. Yeah. Like I think it's more common to see that, when you are switching up roles.
Right. So I guess why big picture starting, like, why do you think that, I guess that's probably a loaded question, but why do you think that is? Why do you think the medical world, because I know it's not just nursing, it's the medical world in general.
Yeah.
Why do you think that that has like this toxic environment sometimes?
Yeah. So I think this is a really layered question. We could probably do another podcast just on this, but I think if I had to whittle it down, I think that on a macro level, what I've observed, both from caring on a personal level for, hospitalists and a lot of healthcare workers, but also in my practice, is that the hierarchical nature itself of the healthcare world makes it really easy for there to be abuses of power because there are power dynamics that are supported by the system. And it's tricky because these hierarchies exist for also a reason, and often a really valid and good reason, but it can be very insidious. It can be easy for people to take advantage of those hierarchies by abusing the power. So that's one part of it,
I feel like that's probably the biggest overarching, totally, the biggest thing. And I love that you pointed out too, that these are hierarchies that are I don't know if the word is needed, but they're in place for almost a reason, in the sense that there has to be the one person that makes the call at the end of the day and not a million people, a doctor or the charge nurse or things like that. And then because that's the way that it's set up and the way that it's needed, it does lead to, that's interesting. I've actually never thought about it that way, but we do sort of need that structure in the setting when it comes down to it. Interesting.
Right. But it can be easy for certain personalities when they land in those positions. And I hear more of frankly, bullying from charge nurses. That's what I'm hearing a lot is younger nurses or nurses that are transitioned into a new role, a new environment. And they're like, oh my gosh, I feel like the charge nurse is out to get me. And it's really tough because there's a natural, again, this hierarchy.
Right. I also feel and I think that's something we touched on too, the generational thing is also big.
Yeah.
And that I feel like Gen Z, which is wonderful. I love them for this. They're kind of coming in and being like, I hate this. We got to change this. But then the people who have been in it a while are still like, no, this is how we do it.
Yeah. Yeah. Well, I think we see this a lot in all sorts of places in our society of folks that have endured and been through a lot, really feeling like, well, you also need to endure and go through a lot. Right? I had to live through this. I suffered and experienced the pain. You got to do it too.
Oh my gosh. I catch myself, and I am the biggest proponent for being not young to or nice to our sweet little youngins, but I catch myself sometimes when I hear them being like, I'm like, this is the way buckle up, sweetheart. I find myself thinking that sometimes, and I need to catch myself,
Yeah. And I think it's tricky. There's a nuance to this conversation. There's a both and an and, because I do think that depending on subspecialty and what you're dealing with on the day to day, there is a real need to also be able to compartmentalize and have a thick skin and get it done and focus on patient care. But again, it can be that the power differentials can really create an environment where if you are if you are underneath someone that is really kind of toxic, right, and kind of almost thrives off of feeling in control and in power, it can be really unsafe.
And I almost wonder if some people don't really know that that's something within them until they get into these roles of power.
Yeah.
And then they're like, oh, and then maybe, I'm not sure. Interesting. Yeah. I also have noticed too, why do you think that I'm sure it's might be maybe hard to answer, but different personalities or different reasons that this happens within roles or like units or specialty?
Yeah. Yeah. So
Yeah.
it's, and I think we were talking about this earlier. I'm like, I'm
Yeah.
always really nervous to sort of say that there are certain like tendencies in certain roles.
Right.
But of course, I mean, there are, right? Like, you know, we can say this even for therapists. Like a lot of therapists are attracted to the fields and becoming helpers because they themselves know what it's like to have needed help and to have leaned out and reached out and seen this and seen how powerful that is. And so a lot of people find themselves doing this work because they also have had their own lived histories, whether it's like they want to be caretakers, or if they end up in a position, for example, they are a charge nurse or they are the attending at the end of the line. There may be something about their personality that really feels safe and in control and powerful by having that position, right? So you can imagine how this could attract, though, at the same time, people that are using that position in the workplace to kind of make up for internal deficits deep down, which is why we sometimes hear this like adage of surgeons kind of getting, you know, oh, like so many surgeons have narcissistic personality disorder. That's a really common one, right? You know, and so while we don't want to have such binary and judgmental, you know, we don't want to throw those labels like, you know, like that.
Right.
At the same time, there are some pieces to this, you know, folks that have not processed certain things.
Right. Man, I want to add that too. Like when we come like later, I want to remember to talk about that, or just now, like to remember that. I'm thinking of that for myself too. Like when I'm feeling that in the moment, or when I feel like I'm being quote hazed or bullied, or maybe not even that severe, but just their energy is off towards me because I'm the new person, or they don't trust me yet, or I don't really know what it is. But to try to think of, it's just like really an issue with them and not an issue necessarily, but something they're going on, like that's going on in theirs. I feel like that's maybe a helpful way to try to reframe it when you're in the moment, maybe too.
Yeah. Yeah, definitely. This is one of the kind of strategies that hopefully we can talk about, you know.
Right.
And then I also, the piece too, I think, you know, it would be, you know, we have to talk about trauma, right? So I think so much of the bullying and the toxicity is supported because a lot of healthcare workers are traumatized. They might not know it. Like we talked about this in the vicarious trauma episode.
Yes, which by the way, you guys should go listen to that.
Yeah, but there's rampant vicarious trauma. People are dysregulated, and we don't use our highest, most sophisticated skills when we are dysregulated as well.
On top of that, like the trauma, but I know we talked about too, like high stress, long work hours. Like I feel like these are all things that even maybe someone who just my example earlier, when I feel like I do have a younger person and my first instinct is to be like, buckle up, honey. Like, this is how it is. I am only at that point when I have had like a terrible day. And then they're saying something like that, or, you know, things like that. So I think that like the high stress, the long hours, the just exhaustion, the trauma, maybe like will make someone react like this when maybe it's not innately in their nature at first. And then they just, they're under stress basically.
For sure. And what I'm hearing you name is a version of compassion fatigue, like kind of an empathy fatigue, right? Like buckle up, you know, we're going to be seeing patient after patient suffering today. Like get over it kind of, right?
Let's get it together. Yeah.
So
I try really hard to be mindful of it, but you like exactly like you said, when you're like under these high pressure things, you don't have the time to sit and be mindful. So maybe that's coming from that perspective too. Interesting. I also wanted to point out too, because I feel like what you just said is you're seeing this more in new nurses. And I have noticed personally within myself, but also just observation of other things, that I feel like this starts a lot in preceptorship. I don't know if you've heard, I know that charge nurses is a huge thing, but I also have heard it within people feeling this with their preceptor, the person who's supposed to be teaching them, learning them, or helping them grow. And I have just seen it personally make or break a nurse's confidence, their ability to trust themselves. It starts within that first, because, you know, everyone listening to this knows, and I'm sure within your field too, nursing school doesn't teach us really what we actually need to know. We got the basics. The learning is going to happen the second you hit that floor. Yeah. And if you are with someone who is a nurse bully and who looks down upon you for not knowing things when you're there to learn the things, right, it sets up this thing. And I've seen that so many times. And I think that's something that we don't have time to talk about probably on this podcast, but as a career and a profession, we really need to stop putting these people in charge of growing our new nurses. Oh yeah. You know, if they have a history of being this way or former complaints, the other side of that is that typically the ones who are bullying are the ones who have been on the units the longest. So they probably are precepting. So it's kind of like a catch-22 there for sure.
Yeah. Well, it's interesting because I experienced this even as a therapist, and I had my own biases coming into the field of like, oh my gosh, being a therapist, all the supervisors that I work for are going to be safe, right? Mm-hmm. Like they're going to be, especially if they're like a trauma-informed supervisor. Mm-hmm. Mm-hmm. Surprise, surprise. That's not the case. I ran into a lot of very unsafe people, and you hear rampant stories, and that's in therapy. So you can imagine in nursing where there's even less focus on one's nervous system and the psychological, the relational. Of course, we're going to have mentors that are not mentoring in a way that's actually effective, right? Mm-hmm. And what I mean by that is effective in helping their nurses be regulated and kind of in that wise energy so that they can make the best decisions. Right. When we shame people, when we bully people, we're contributing to their dysregulation. Mm-hmm. And when people are dysregulated, they are going to make more mistakes. Mm-hmm. Right?
Very much so. Yeah.
Yeah.
I mean, even within me, I've been a nurse 13 years almost. And, you know, starting ICU, I just remember this was kind of recently, I'll share this story. I wasn't even I'm off orientation. I'm my own nurse, but it's this one particular nurse who still knows that I'm new within the ICU role. And I was giving some bolus off a pump, and she just, I wish I could remember specifically the way she's saying it, but she was asking me, because in pediatrics, we do everything based on kilograms, how they weigh. Mm-hmm. She was asking me, what's the dose based on kilos? I kept telling her the dose based on not. Uh-huh. And she said, what is it? What is it in kilos? And the way she was saying it, and I'm like, I know what I'm talking about. And I knew my patient like the back of my hand. And I'm like, but when someone comes at you in that way, it shuts me down. And so in that moment, I felt like I even looked dumber than she already clearly thought I was, when really that's not the case. It's just the way that she was coming at me was like, it just shut me down completely. And I feel like I'm okay. You know, I'm a good nurse, and I'm confident within myself, but that situation was only okay because I am confident now. Like if we're doing that to our new grad nurses, there's no wonder they're walking out. 60% of them are leaving, you know, that's crazy.
Right.
I think this woman is a preceptor. Sorry.
Oh gosh.
I know.
To your point. Well, yeah. And I think what you just mentioned brings up the adage that I often share to a lot of my couples, actually, which is tone trumps message, right? Yes. But tone is also really difficult to call out. So if you are experiencing workplace bullying or these kinds of aggressive, it can be difficult to call it out because the person can easily just say, what? I was just asking for the information, right? But you felt that tone and the way it was said, and it was said in such a way that sparked something in you, which is, I've kind of heard you say, I felt like I was dumb. Mm-hmm. It made me feel small, right?
Yeah. Yes.
And then you notice that your own pattern, when that hits you and that hits that part of self, is to like clam up, withdraw. Mm-hmm. So makes sense.
And that was a side that I've never even seen of myself. I feel like if I have coworkers listening to this, or the ones that have worked with me in the past, would be like, you shut down? Like, are you kidding me? Because that is not, I'll go toe to toe with people usually, but it was just something about that. And I'm like, it really made me be like, wow, we cannot do this to our sweet little baby nurses, because they'll never stay. Truly. Anyway. Okay. So I feel like we've listed so many things, and I feel like all of them play an equally important role in sort of the way that we've got to this, where we are in the state of healthcare right now and the way it has been. I'm hopeful that Gen Z will get us more aware of these things. I think that, that they have a special unique thing that they're doing with certain things and talking about feelings. And I hope that does bring some awareness to what's going on.
Yeah.
I guess we sort of talked about this too. One question I had for you, what are some common themes that you see within nurses specifically? I do think you mentioned like the charge nurses, the preceptors.
Yeah.
Do you see a lot of like issues with nurse and physicians necessarily?
Yeah, I think that, so a couple things. I do think overall, if I really zoom out and think about all the folks I've supported, I would say physicians often have a much stronger, I'm going to use some parts language, like therapy language, but like protective parts that are really, really good at staying zipped up.
Okay.
Right. So like what I mean by that is there might be a tornado going on the inside, but they are really good at not showing it. And it causes distress behind the scenes. We don't necessarily see it. But, you know, one of the most common things physicians tell me in my office is I must be the only person experiencing this because none of my attending friends seem to be having this issue. And yet all their attending friends are in my office saying the same thing. So they're zipped up. Whereas I do think maybe nurses, I notice, have a little bit more accessibility sometimes to their emotional world, or they feel a little bit less clamped up and compartmentalized. So sometimes they can spill over and come in and be like, gosh, I got dysregulated during my shift last night. Right. And so that's like one theme I noticed, but it's nuanced.
Right.
Yeah.
That's good. I feel like that's good of us to be able to at least be able to like put a name to the feeling, or at least be getting better or trying to work towards that. But you did mention, I remember, I don't know if this is still the case, or I remember when we first talked to you, mentioned that nurses are the hardest ones to consistently show up to therapy. Is that still true?
Yes, unfortunately it is. And, you know, I have to give nurses a lot of credit. A lot of this has to do, again, with like, you know, being shift workers, and it can be difficult to find the scheduling. They're also exhausted. Whereas physicians that maybe have like a more standard clinic, or, you know, they only have 12 service blocks a year, it can be easier for them to actually make it to therapy. So that is a really big, I think, factor and barrier. But also, I do think that there is just a certain kind of a different ethos. Like I notice physicians are like, I'm going to come in and I'm going to tackle this therapy thing. I'm going to be really good at this. Like, and so they're like kind of determined to like,
they want to be good at everything. Right.
Right. Whereas I notice nurses, and because so many of the nurses I support are already coming in and are feeling a little bit more unraveled to begin with, right? That it can be really scary to do the kinds of therapy that I specifically specialize in, which is more of the depth work and more experiential, processing deeper things. And a lot of nurses tell me, I want to do this work, but I also don't want to become dysregulated because I am already on thin ice. And so that's what's hard, is that the process is slow, and it takes a long time actually, because we don't want nurses to feel flooded by the therapeutic process and unable to do their jobs.
Yeah, I could see that. I could really see that being a big thing.
So I'm really used to nurses disappearing on me, all this to say. Like we'll do some really great work for a few months. We'll start getting deep. You know, we've done a lot of work to help them contain so they can still show up to their shifts. And then all of a sudden I won't hear from them. That is very common with my nurses. But they come back. They come back.
Okay, I'm like wiping sweat off my brow because I did that. I mean, I was going for relationship type things when I went to therapy, but I also totally ghosted her. But there were multiple reasons. So I'm like, guilty as charged.
Yeah.
Interesting. Okay, so little advice, if that's something you've done or you've thought about, maybe if you're feeling overwhelmed, like pull it back a little bit, or show up but go like less or something. What would you say to them?
Yeah, I would just say that, you know, try to find a therapist that's ideally really, really trauma informed, so that they can really center the importance of going slow, nervous system regulation, and then also buckling up, because the challenge is so many people want to come into therapy and they think, okay, I'm going to go in for some quick tips and tricks and coping skills, right? Like more CBT style, like talk therapy. But the reality is a lot of times the things that are triggering nurses run deep. They run deep. Their views of self and views of others. My needs don't matter. I'm not good enough. No one's ever seen me. And that is really what's getting activated on a very subconscious level by these toxic colleagues. And
Wow.
so that takes time to process. We can't do that overnight. And it's going to be longitudinal, and it's going to take, frankly, years in some cases, depending on the level of trauma that folks are showing up with.
Mm-hmm. Yeah, I can completely see how that would, they, think they're signing up for one thing and then they get into it and they're like, never mind.
Right. And then it's overwhelming, so they bail. So I have a lot of empathy for that.
Right. And so sort of along those lines, something else I was wondering too, or what are some like physical signs? I think that it's probably hard a little bit, physical and mental well-being, like effects of working in these environments that you've seen in your practice.
Yeah. Yeah. It's interesting. I literally had a session last night with a healthcare worker who came in and they were like, I had a headache all week since our last EMDR session. We really pulled up a lot of things, and then we did more processing. And by the end of the session, they said, okay, that headache is gone. I feel relief. So there are real connections. And I know that this can feel woo-woo. And for some people that are in the healthcare, I get a lot of rolled eyes sometimes. But of course, there is a connection between the physical manifestation of emotion and distress and dysregulation and what's going on up here, right?
I am hoping that it's 2025 and us in the medical field can finally start admitting that there absolutely is a deep tie, to mental and physical, for sure.
So to answer your question in short, sleep disturbances, feeling wound up and unable to relax once you aren't in a calm environment, right? Mm-hmm. Feeling a lot of rumination. So the toxic workplace specific to this, a ton of rumination. Like I cannot stop thinking about this comment that the charge nurse made last week. You might notice depression. You might notice that when you get off work, you just want to dissociate and, binge watch shows or social media. So those are a few things that you might start to notice. Yeah.
Guilty as charged on the binge watching and the social media, for sure.
Yeah.
For sure. I also know that I've just noticed, because I'm trying to be more aware, I'm 13 years in and I'm just now trying to be more aware, but I have also noticed that I feel like GI symptoms, me personally, a lot too. Like
totally.
When I know that I'm working with a certain person, even recently, even with this transition into the PICU, I feel nauseous. Mm-hmm. And I'm like, God, I gaslight myself. I'm like, I need to snap out of it. It's not this bad.
Yeah.
But yeah, I can see that. And I always think, if I'm feeling like this, I just can't even imagine what the new nurses or the ones who, don't have that confidence built up are feeling.
Oh yeah. GI issues are huge, as well as like tightness in chest, shortness of breath, feeling shaky. Those are really common ones as well on a physical level.
Mm-hmm. And then I feel like every episode we mention this book, but the book Trauma Stewardship that you shared with me, that I finally, since last time we spoke, I finished it. It's wonderful. It's by Laura Vandernoot Lipsky. There's a quote I just wanted to read that says, Goli Jansen, an associate professor at Eastern Washington University, recently concluded a study in which she found that, quote, when people perceive their organizations to be supportive, they experience lower levels of vicarious trauma, which you would think that, of course, but that's like, there's studies on this. Like there's studies that if you are surrounded by support and things like that, that you are going to be less traumatized in general, especially career-wise. I just think that's important. And, I just really hope that more organizations kind of take this bullying thing more seriously.
Yeah. Yeah. And unfortunately, when I was doing my own research on this, I was looking just kind of anecdotally on what people were posting on social media. And I saw so many videos of nurses talking about how they took steps to try to advocate for themselves because they were in unsafe or abusive positions, and they were punished. They were, reprimanded by HR. And so, yes, to your point, it is really difficult. You can't really outrun toxic systems on your own. Like these are systemic issues.
Mm-hmm. That's a perfect segue, because I also want to get into practical steps, because I think that we could talk about this, all the time. We can do therapy and we can really work out within ourselves, which is perfect and what we need to do. But at the end of the day, sometimes action is needed and people are too scared to do it, or they don't exactly know how to go. Even myself, where I've been in situations that went wonderfully, I still second guess myself. And I'm like, should I even like approach somebody about this? Should I just let it go? Then if I let it go, then that affects me in the long run.
Yeah.
So I guess let's just go over maybe practical steps to confront a coworker or your whatever the situation is, which I know it's hard because I'm sure that it's probably situational based.
Totally. Well, it's tricky, right? Because I always struggle with this as a trauma therapist, because I never want anyone who sets foot into my office to think that my goal is for them to learn how to tolerate abuse and how to make it okay when it's not, right? There are certain things that absolutely cross lines. And so I think before we get into individual things that nurses can do on their own to sort of work through some of this, it is important to name that, like, if a colleague's behavior is abusive or threatening, if it's impacting patient care, my number one advice would be document everything and try to find the appropriate channels to report it, appropriately. And it is really difficult though, because as we're seeing in a lot of these videos I found, sometimes the systems will become punitive so know the system that you're in, pay attention to what you've observed. Sometimes it might get to the point where you do need to leave. Like if it's really a situation where, they are not supporting you and you've come forward and you've documented things, then there might come a point where you just really have to weigh, is this worth my mental, psychological, spiritual health, physical health? And you might have to leave.
It's almost like weighing the pros and cons in your head. Like, so what worst case, I kind of do worst case scenario in my head for almost everything in a way that almost calms. That's the way I calm my anxiety about how something is going to go. And so it's almost like worst case scenario, I get let go for standing up for myself, or I leave for standing up for myself for something that's truly abuse.
Right.
And if that's the worst case, then aren't you better off? So I feel like, just sort of trying to think about it in those terms too.
So that is the worst case scenario, right? Sometimes though, you will find support, and especially if you've documented everything and, you will find recourse and support and it'll be addressed. But then we can also get into things that we can do individually, right? To tend to ourselves as much as possible when we're facing toxic coworkers.
Right. I guess I have an example. Maybe that will help. I will never forget. And I was still a new nurse, and looking back on it, I think about it all the time because of course I would handle it differently. I was just sort of silent in the moment, but I'll never forget. I walked into, I don't even remember what the specific issue was. It was a neurosurgery patient, kiddo. And I remember I had been trying to get a hold of the doctor all day. And I'm pretty sure I was concerned because we were having increased episodes of vomiting. And that, of course, is a sign for us, that are in the field, knowing that something is wrong neurologically, or it could be a sign of something. So, of course, I'm going to assume a neurosurgeon is going to be concerned about that. So I remember trying to notify them of this. And finally, the doctor comes to bedside and he's talking to the mom. I can't be there when the initial conversation started, but I remember being like, okay, I'm done in my other room. I'm going to go and see how this conversation is going. And before I can walk in the room, I overhear the neurosurgeon say, "This nurse hasn't told me that he's been throwing up all day. Your nurse hasn't told me anything." And luckily, I am so excited. The patient's mom, I'll never forget her. I'm so excited for her. But I heard her say, she's been in the room when she's called you, and I've heard her call you and tell you. And I'm like, oh my gosh, thank you. But so that was like instantly gratifying. But had that not been the case, I mean, not only did I walk in on you putting a fellow coworker down, but you also were not telling the truth. And also you're fostering like a distrust in the patient and with their nurse. And that just, of course, really concerned me. And I remember also, I didn't confront in the moment, it's not really appropriate. It's there, a final,
Right.
like you can, well, the mom did it for me anyway. So that was amazing. But I remember going to my manager afterwards and being like, listen, this is not okay. It's one thing to just not like me, or maybe there was a miscommunication, but this wasn't that case. He was blatantly putting me down,
Yeah.
And making something up to a family that can cause all these things. And nothing happened. He essentially, the manager was like, yeah, I mean, I don't even remember what he said, but it was basically like, get over it, is the sense that I got. And yeah, I guess, in that situation, first of all, do you see situations like that? And then kind of what is the thing to do there?
Oh yeah. I mean, I've heard of a lot of situations like this,
Right.
unfortunately, and I've also been privy on the back end, without disclosing too much about my personal life. I have heard also a lot of physicians that do advocate strongly for their coordinators, for their nursing. I mean, a lot of appreciation too. So I do like, there are these bad eggs, but there are a lot of physicians that absolutely, deeply respect what you all do as nurses. And so also kind of noticing, and this gets to some of the sort of tips, finding allies and support, finding those colleagues on the floor that are willing to bat for you, and that are supportive, and that are, that do care for you, because there are those people there, and leaning into them as much as possible can be helpful. Right. And maybe not necessarily going to them and like venting about what you experienced, but leaning into them insofar as like, making sure that those relationships are strong. Focus on those relationships.
Right. That's true, because even though you feel comfort in someone, you still sometimes have to be a little bit careful of the venting and who you share what with. And that's another part of being new that's like stressful, is because you don't know who's really like in cahoots, or like who's with who, or, you can't really trust certain people.
Right.
But yeah, well, I think spinning that and thinking about it more as like building a strong relationship with them, that's not involving the venting or so that's solid.
Yeah. I mean, just making sure that you're noticing how you feel around certain colleagues, and those colleagues that are safe and supportive, nurturing those collegiate relationships, because that's important, The other piece I would say, and this is a big one that I was putting down, is sort of like, what can we do? Is keep your own nervous system regulated as much as possible. Right. So trying, and it's really hard, because what I just heard is sort of almost like an injustice. So I can imagine the trigger there is, this is unfair. This is untrue. Right. So also noticing and identifying one's triggers. What are things that we do feel sensitive around? And getting curious about if there are other pieces or other experiences in your life that have also made that to be a little bit of an extra sore spot, right? I mean, injustice is injustice, right? Catching somebody lying, and that's going to be triggering no matter what. However, if you are somebody that, for example, grew up in a home where you experienced a lot of these types of behaviors, or you were in a relationship, that might be a little bit extra raw. And you might notice yourself getting triggered around that in a deeper and more profound way than maybe if you hadn't had those experiences.
Right. So look within, for sure. I also love so much what you said about documenting everything. Shout out to my mom. She is not in healthcare, but she has been a manager and a boss for years, which that was her career for a long time. And she ingrained into me in so many situations, in situations with friends, in situations with teachers, just growing up, every single situation. She's like, every chance you can, write down the date something happened and what happened. And it reflects a pattern. You just need that proof, because I think us nurses are so feelings based, which that's what makes us so wonderful and beautiful. But when we go to if we finally make the decision to go to management about something, and all we can come up with when we're finally there and we finally get the courage is, well, she's mean to me.
Right.
And we cannot specifically give one examples or two dates to show how long it's been going on, to show, I mean, even if the most caring, sympathetic manager, she's got nothing. She has nothing to help you.
Right.
She can't bring that forward to HR. She can't bring that forward to the person themselves and be like, hey, someone says they're being mean to you. Or you're being mean to them. I think that it comes with, you really try to, and I know that takes an extra step of effort, just like, we don't want to take that extra step to effort to really, but if it's something so severe that it's causing you this distress, I love that you mentioned that, because I can't emphasize enough. I give that advice to new grads when they ask me for advice too, is to write everything down.
Yeah. Yeah.
Because not only for helping go to management, but also sometimes just writing it down helps you feel better. And then you realize, okay, I think I'm just going to process this, write it down, go on my way, see if it happens again type thing. I think it's both for a processing purpose and also for future, if you go to somebody about it.
Yes. Yeah, for sure.
Yeah.
And I think anything that also involves patient, that jeopardizes patient care, of course. I think that that should be like, highlighted in your notes, right?
Yes.
And I think also to be really fair, there is, an uptick in therapy speak, in our world. And people love to use the word toxic. People love to use the word abuse and trauma. I feel like we hear that word daily now, right?
Yes.
Which has watered down the impact, right? So people can be mean and they can be prickly around the edges. Is that traumatic? I don't know, right? I would say no.
Right.
I would say no. I would say it's unpleasant. It could be triggering pieces of your own history that feel in some ways really traumatic to your nervous system. But it is going to be difficult to have a manager or somebody in admin like look at that, right? Like HR and really feel like that is traumatic. So there is that piece to this too, is trying to maybe get an external perspective from someone like a therapist or a dear friend or something like that, so that you can have a little bit of a checks and balances, because otherwise we might start inappropriately labeling things as like, this is so toxic. And it's like that person had a bad day and they were snippy.
Yes. I love that you brought this up. I love it so much, because I agree. I hear it so much. I don't know. I feel like just being, I don't know, I hate to bring generational things into this again, but you're so right. Like Gen Z's bringing up the therapy things, and that's fantastic. And then I'm a millennial, so I'm like in the middle, and I kind of see like, I almost feel like I see in the middle of like, what you're saying, essentially. I don't know how to word what I'm saying. But yeah, the two extremes, exactly. And I'm almost like in the middle being like, okay, that person just is like this to everybody, and she's not toxic. She just is that way. Like that's just Susan, or whatever her name is. Like that's just Susan, or that's just Nancy.
Deborah's cranky.
She's cranky. She's just cranky. And Deborah will tell you she's cranky. Like Deborah herself will say it. Like, I think that there is like and that's just getting to know people. That's why I've taken a pot, even personally in the ICU. I'm like, whoo, these personalities are a little pricklier than my other friends on the floors and the step down and other places I've worked. Just a little more serious about stuff. And I'm just learning that. And I think that the longer I've been there, the more I'm learning that really doesn't have anything to do with me. I'm observing that they are like that with everyone.
Totally.
And that has helped. I don't love it still. It's still unpleasant. It's not my favorite to work next to that certain person sometimes, but that's just what it is. And you're going to get that in every job that you ever do. I think that some people think that it's nursing and then it's toxic, and it's really just life. But then there are, like you said, times where it's an effect on patient safety. It's an effect on your physical health, your emotional health. And that's when you have to really take action, and documenting is the first step. And I definitely give that advice too, because it's just so helpful, because your manager can't help you if she doesn't have specific examples on what happened.
Right. And I think some of the keys here to differentiate is like, is this targeted? Is this really like, is there something that's happening specific to you, between you and this person, that makes it feel really targeted? Is there any sort of discriminatory language, any overt racism, or even more implicit that you're picking up on that would be important to notice, right? And then also, looking holistically at that person, like how is this person's personality on the day-to-day, right? Mm-hmm. And I think that's important to weigh when you're considering whether this is actually abuse or it's actually, toxic behavior pointed to you.
Right. I had a couple people reach out on Instagram. I asked what people would want to know from this episode. And a huge one is what happens when you feel like the toxic person or the person that is really affecting you or abusing or whatever you want to call it is your manager.
Yeah.
How does your advice differ for those people?
Yeah, I mean, it's really tough. That's not a fun situation to be in, obviously.
Right.
One thing I would say is, again, I think I've shared this on some of the other podcasts we've done, Jeri, but it's this idea of making sure that certain parts of self are not showing up on the floor. Meaning, I will work with my own clients sometimes on when you get to work, I want you to sit in your car for 1 minute, set a timer for 60 seconds. And I want to see if we can get you into that, like whatever you want to call it, wise self, your adult self energy, that anchored, grounded feeling, and have those younger parts, the parts that feel triggered because they don't feel like they're enough, the parts that feel maybe a little bit more sensitive to certain types of triggers from people. Have them take a step back and try to show up to work in that grounded, wise place, right? Because if we're able to do that, it's easier to stay anchored and to get less unmoored by other people's turbulence. So that's the first thing, that I would say.
Yeah, I love that. I feel like I could even still probably benefit from, well, of course we all could, but I could benefit from doing that even maybe tonight before I go to work.
Yeah.
Yeah, it helps. It helps. Also just like with patients too, the prickly personalities aren't even also necessarily your coworkers. It's everybody that you're going to encounter that day.
Right. And then, I think finding a way to, I really love like some of the more existential therapy kind of pieces, which one big one is honoring the pain, like validate your reality, right? So making sure that you do have supports and people you can process with outside of work so that you can really validate the pain of being in that position with a manager. But also consider choice. What choices do I have? So I can anchor up and I can try my best to create boundaries and to stick to those emotional boundaries, right? Not letting people infiltrate my bubble as much or those parts. I can also choose to document. I can choose to eventually leave if it gets bad enough. But really thinking like, what choices do I have in front of me and leaning into those choices.
Mm-hmm. I just also want to share an experience I've had with a manager before. I mean, I already shared the other one, but another one too. And something that I did to work through it. And there was an incident where I was brought in for an incident report that was filed. It involved me and another nurse and something else. And I honestly forget what it even was, but it really just talked it out. But after that meeting, this manager didn't look me in the eye or say hi to me in the hallway. She would say hi. I mean, it was very intentional and very, so silly. I was like, oh my gosh, she really is ignoring. She's really giving me the silent treatment. The manager.
Yeah.
It was shocking. And I remember, of course, at first being like so mad and like, who can I report this to? Who can I tell about this? And then I just like had to sleep on it, take a sec back and be like, it doesn't matter to me. Like she shouldn't be doing this, but I just can't, like, it's not me. I think that I've heard other things about her doing this to other people. And this is just the way she does it. And I guess maybe my situation was a little different because I knew I was leaving. So that's a little bit different in that moment. But if it's something that you can't leave or you can't stay, I guess in that situation, would you confront her? Would you actually, I do think on my exit interview that I mentioned it, but I mentioned it very respectfully, calmly.
Yeah.
I just said, there was a time, where you brought me in, and then the weeks following that, you seemed to not intentionally not say hi to me in the hallway. Like you were mad at me.
Yeah.
And, I remember her being really shocked that I even said it. And she was like, I guess maybe I did do that. She goes, I'm sorry. I should probably look at that. I'm like, oh my gosh, you just said sorry.
Wow. Okay.
So sometimes it's like, you have to I know. I kind of forgot this even happened until we were like, going through this example. But I think it's just like, moral of the story, weighing whether something is important enough to you. In that moment, it wasn't to me because I knew I was leaving. I just am like, I can only care about so many things. And that was just like, whatever, I don't care. But it almost was worth it to me in the exit interview to at least bring it up, because I'm like, maybe she can grow from this. Maybe she doesn't know she's doing it. Maybe if I say it in the right way,
Yeah.
she will, or she could completely hate me even more and then fine,
Right.
Right.
Yeah. I mean, this is tricky and it is very nuanced
Mm-hmm.
because you might be dealing with someone that really does have, frankly, like a personality disorder where if you were to approach and call something out in even the most like textbook therapy, like therapist approved manner, it would
Right.
not go well. Right. Or,
It's
but
true.
there are some times where it's like if you are going to be in a system for a long time, you don't want to leave your job and you have this relationship to preserve with someone, there are ways that we can, again, from that anchored, grounded place, name what we're experiencing, right? I'm more inclined to do that, but again, I'm a leaner inner and more of a pursuer myself. So I'm
Mm-hmm.
tend to be someone to more face things and with compassion. That again, not everybody has that capacity, which is okay. But I would
Right.
probably say something like, hey, like I'm nervous. And I usually always start conversations like this with naming how it feels to have the conversation. Like I'm nervous to bring this up because I really do value the relationship we have, and I value your thoughts. But I'm noticing that I'm feeling like there's something going on between us, like that you're upset. I'm noticing that you didn't talk to me in the hallway, and I'm curious about that. And I think that people, giving people also the benefit of like people do have bad days, and they have these strategies of freezing, fighting, icing out when they get triggered. And so if you have the capacity to approach them in a certain kind of way, you'd be surprised. Sometimes it can go really well, actually.
Right. I love that. I love that you saying like naming the feeling, because it almost like, I don't know, it almost like instead of them getting on an immediate defensiveness,
Mm-hmm.
and then that's when I go to, they're almost like their guard is like, oh, okay.
Yeah.
Like naming how you feel first and saying, I'm nervous to have this conversation. I think
Yeah.
that was great.
It can be hard though. Like I do have a lot of empathy that that's a risk and that it
Right.
can not always go the way that you intend. People can also be punitive on the other end of it. So also getting ready for whatever the fallout is of you taking that risk. But I am a big fan of like learning strategies for how to not just immediately disconnect and write people off when we
Mm-hmm.
have a negative experience with them. I think that's a really important life skill that we don't talk about enough culturally.
I agree, because I think about so many times that someone probably on my bad day had a bad experience with me. Probably. I'm sure there's
Yeah.
other out there. And that's just like day to day, not who I am, especially on night shift. I feel like my night shift self is a different version than my day shift self. I'm like, you're going to love, if you like me on nights, you're going to love me on days. I'm a totally different human. So I'm like,
Yeah.
I think I try to like be sympathetic in the sense that I'm sure that I've not rubbed people the right way, and hopefully they would give me another chance too.
Right. Right.
Just like I would, I should be doing for other people too.
Yeah.
I also think like I just personally, and I think about, I remember we talked about this too. I was a big Dr. Phil kid, like growing up. Like I would love going home just so I could watch Oprah, Dr. Phil. And as much as it was like, filled with a lot of silly stuff, I do remember one time him saying that you cannot change, we are not capable of changing anyone's behavior. The only thing we're actually capable of changing is our reactions to that behavior.
Mm-hmm.
And it sort of stems along the same famous quote, I think was Eleanor Roosevelt, that no one can make you feel inferior without your consent. I mean, and I try so hard to remember that in everyday situations, in work situations, especially work situations where nothing I'm going to do will change this person's behavior if they don't change it for themselves. So the
Mm-hmm.
only thing I can do in this moment is change my reactions to it and how much energy I'm going to give it.
Yeah.
And that's obviously easier said than done. But I just try to, when I do mentor new travel, because I know travel nurses face a lot of the hazing and the bullying as well.
Right.
When I do mentor new travel nurses, I try so hard to ingrain that and just tell them to keep repeating that to themselves, because at the end of the day, so much of this, which is what you've covered and what you said, doesn't even have to do with us. It doesn't
Mm-hmm.
even have to do with me, Jeri, specifically. Oh my gosh. Let me just share a quick little story on that too. there was a travel assignment I went to one time too that, I mean, the tension was palpable. It was day one, and I will never forget. Well, I was 24 years old, so I am young. I'm a brand new nurse. It was only my second travel assignment, and I'd only been a nurse for maybe like 2 years, probably 2 or 3 years. And I walk in, and it's a clinic assignment. It's my only clinic job I've ever done. And I walk in, and they were like, "Hi, everybody. This is Jeri, the travel nurse." I mean, you could have heard a pin drop. No one said hi. So it was like 5 ladies. No one even looked up from their screen. It was like, I almost felt like I was getting punked. I'm like, "Hi, everybody. Nice to meet you." And I remember walking away just like almost sick to my stomach. Like, what was that? And I mean, it continued. That assignment was 5 months. I mean, I'm 3 months into it, and I'm like, "Mom, I'm miserable. This is like, they are just, I'm trying so hard, and I'm so like bubbly and friendly and trying to learn." And then I finally am connecting with one of the like younger ones, and she's so sweet. And we became good friends, me and another, one of the younger ones, like around my same age. And I eventually end up finding out that I was the first traveler this place had ever hired. There was another employee who wanted to fill in. Well, I was filling in for 2 different maternities. Another employee who wanted to fill in, but they told her, "No, we'd rather have an experienced BSN nurse and not you," basically. And all of the nurses in this clinic were ASN. And so they kind of took that as like okay, so we're not good enough. So then when me, a 24-year-old little BSN nurse who did not know as much as they did, but it's because I didn't come from clinic. I don't know anything about peds, or at that point I knew nothing about peds ortho. So when I came in young and a BSN, and also not really knowing as much as I guess they maybe had in their mind that I should know, because they were kind of like, it had nothing to do with me. Like, I can't even tell you the relief I felt once she told me that, because I'm like, this entire time I was thinking that I was just the most hated person. And I'm like, it could have been anybody that walked into this room because of the way that it was set up. I was set up.
Yeah, so, totally.
I share that story a lot with people and by the end of it, they threw me a going away party. They threw me because I love baked potatoes. They threw me a baked potato bar. I'm pretty sure it was, like, with all the toppings and all kinds of stuff. So I'm like, see, once they got over it, I got over it. Everybody got over it. But I share that story a lot because I'm like, it's just moral of the story. Like, most of the time it has freaking nothing to do with you.
Yeah. It sounds like the scarcity and their own feelings of not good, like you said, not good enough, got activated. And then when people have those parts of self that get activated, the shame or the disappointment, they go to the strategy that they've rehearsed. And it sounds like that strategy is kind of to freeze and fight and kind of to guard up, right? Not let people in. And then you experience that on your side. And of course, naturally, we're pro-social mammals. You're going to be impacted by that, right?
Right.
So, the quotes you shared are beautiful. And again, it speaks to this idea of choice. We all have choices when we're on the receiving end of other people's actions. I also want to say with empathy, because we are pro-social mammals, of course, people are going to impact us. We all bear impact on one another. And so it's kind of this both and. Like, we do need to address ultimately that the ways that we show up when we get triggered and the ways that our managers or our toxic colleagues show up when they get triggered have impact. It's cyclical, right? And you have choices on how you want to deal with those triggers.
Right. I love this. I feel like we could tell stories, and I'm sure your research, when you were looking up nurse stories, there's so many stories out there, so many TikToks, so many new people. This is just unfortunately something that I think will stay. And just like learning your coworkers is something that we just have to get used to. But in the sense of just bringing it back to like concrete things that we can do, because I know people want those things. I, again, can't stress enough, especially in a case of where you are truly getting bullied, write it all down. Write it all down. Every day, write it down.
Go to the appropriate avenues to get support if you're able to.
Maybe even, I know something I found valuable too is having someone who is also maybe in the nursing field, a nurse manager that isn't working at your institution.
Yeah.
to bounce ideas off of and see like, hey, this is not cool, right? Like,
Find
just
colleagues and mentors.
right, colleagues, mentors. Yeah, reach out to people just to be like, is this really something I should give my time, energy to? Is it really that, bad? Like, or just venting purposes, go to therapy.
Yeah. Yeah.
Yeah.
Resource yourself as much as possible. Really think about maybe like the choices that you have in front of you. Like you do always have choice. You are in the driver's seat of your life. So you get to choose how you want to respond to some of these things. Try to stay as anchored and grounded as possible. Really tend to your nervous system and try to stay like that word anchored is important when other people are kind of giving you like, a tsunami or these, hurricane energies. You try to stay as anchored as you can so you can show up with your most sophisticated strategies.
Yeah. And that comes with time,
Yeah.
especially being a new nurse and, well, just a person in general. But a new nurse, especially, I think the more time you're there, the more you gain confidence in yourself, your knowledge, then you have more of, you feel like you have more of a leg to stand on, sort of, when it comes to defending yourself or taking care of your patients. And
Yeah.
it's painful when you're new and you're getting started and you're like, I have to wait, 1 year, 2 year before people take me seriously. It's like, no, you have to wait that time to feel confident in yourself.
Yes. Yeah.
And
Knowing
that's
thyself.
just, unfortunately, yeah, just knowing yourself. Um, I'm so sad. We're like, have to wrap up on time because we could talk about this
Yeah.
probably for so long, especially with all the stories and things. I guess I just wanted to say a little note that nurses are the only ones who understand what other nurses are going through. All we have is each other. We deal with more sadness and grief than the average person. And our job is tough enough, not to mention the fact that it feels like there is a news article every single week about violence against nurses, which is an entire other episode and
Yeah.
podcast, the violence against healthcare workers. And in almost every scenario that I read, who is there for each other when that happens? It's your coworkers, your other nurses. That's who's there for you.
Yep.
The last thing we need is to be against each other. So when stuff hits the fan, you need each other. And I promise you, being the nurse bully will not earn you the respect that you're seeking in the long run. So I feel like communicating effectively, have each other's backs, support one another. That's just what we need to do. And anyway, I hope this episode helped people. If anyone feels they need more help or want to talk about it more or want to reach out to you, Danielle, where can they find you?
Yeah, they can find me over on my website, DaniellePalomares.com, or on social media, Danielle Palomares MFT.
Amazing. So I hope you guys like this episode. Please take a moment to rate this podcast if you haven't, write a review, leave a comment if you liked it, what you found helpful, or maybe even if you didn't. Again, my name is Jeri Ford, and you can find me on Instagram at JeriLynn_89, or you can find me on the Nurse.org website. And that's it. Thank you so much. And thank you again, Danielle. This was wonderful.
Oh, thank you so much, Jeri. It's been a pleasure.
Bye, everybody.